One thing I realized, Jess, is that we usually have our acknowledgement slide up.
Yeah, I put it up here, but I didn't share it since we're kind of late getting started on the webinar.
Okay.
You like me to real quick?
Yeah, maybe. Just because.
Okay.
Yeah. Thank you. Looks like we're at good place now. Maybe we'll get started since we have panelists, and that always takes a little extra time. And we're delighted to have everybody here. Welcome. My name is Sarah Curran. I'm the director of the Center for Studies in Demography and Ecology, and delighted to be hosting, launching us today. Just a few rules of the game, and then I'll get us started. This is a webinar, Zoom webinar, so there's a Q&A function at the bottom of the bar of your Zoom screen, and that's how we'll be taking in questions along the way. And we may bring you in to give a chance for you to actually ask your question, but do post your questions. I know that our panelists will be delighted to answer them. And I'm very, very pleased to introduce to you Professor Anjum Hajat, who is professor of epidemiology at the University of Washington. Dr. Hajat is also one of our executive committee members and responsible for our primary research area in the health of people and populations. And we're really delighted that she helped to organize our session today. And with that, I'll turn it over to Anjum to introduce everybody on the panel.
Great. Welcome everyone to our panel. It's been a pleasure to coordinate this. I think it's going to be a fabulous panel. So today we're going to be talking about reproductive justice, historical views, and contemporary implications for population health. So I will just do a quick and brief intro of our three panelists, and then we'll jump into the actual panel. So to start off with, we're first going to hear from Dr. Monica McLemore. She is a tenured professor in the Family and Population Health Department and interim director of the Center for Anti-Racism in Nursing at the University of Washington School of Nursing. Her research is primarily focused on reproductive justice, specifically around anti-racist birth equity research, community-informed methods, and policy translation. And I think importantly, her research really goes well beyond academia to include a lot of public-facing op-eds, commentaries, and her work has also been cited in 5 amicus briefs in the Supreme Court in the U.S. Supreme Court. So lots of impact there. Our second panelist we'll hear from is Megan Egan-Torco. She is an associate professor and director of nursing at UW-Bethel. And her scholarship really examines the relationship between power and outcomes in sexual and reproductive health, with a particular focus on racism, homophobia and transphobia, as well as ableism in contraception and abortion. She also does some clinical work with the health department here in Seattle and holds a number of leadership positions in midwifery and nursing associations, including one on the Advisory Council of Clinicians in Abortion Care, among others. And then we'll hear briefly from Taylor Riley. Taylor's going to serve both as our moderator and as a panelist, speaking briefly today about some of the legislative legal activities here in Washington State. But Taylor is a doctoral candidate in epidemiology and also a CSDE trainee. Her research focuses on social and structural determinants of sexual and reproductive health inequities, with a focus on abortion and perinatal care and outcomes. Prior to beginning her doctoral training, Taylor was a senior research associate at the Guttmacher Institute, conducting research on unintended pregnancy, abortion, and contraception. So I will turn it over to Dr. McLemore to begin the panel.
Awesome. Well, first of all, I really appreciate having the opportunity to be here with my colleague, collaborator, and friend, Dr. Megan Egan-Torko, who we've published together, we've been able to present together, and so I'm glad we can tag team this in a way that I hope will be helpful. I prepared some written statements. I'm not going to use any slides, but that also means I'm going to be reading them off of a second screen. Please just know that the Q&A function is there. For people who are go away and come back kind of person, you can hit me up on social media. I'm myself everywhere. And I want to start off by saying I want to thank the Center for Studies in Demography and Ecology to engage on this panel. I use she and her pronouns, and I have a million things to say about demography, ecology, population health, and why those frames are incongruent with reproductive justice, and how they should and could be retrofitted, reformed, and reimagined. So my goal in these brief comments is to activate you all to think differently about the theoretical underpinnings of your work. And the way I'm going to do that is I'm going to start with 3 short stories, then I'm going to introduce this framework that I use, retrofit, reform, and reimagine. And then I'm going to end with some considerations about where we should go, where we are in reproductive health rights and justice. And then I'm going to turn it over to Dr. Egan-Torko. So, please feel free to use the Q&A. Please feel free to use social media. Please feel free to engage with us in ways that make sense. So let me just start by saying in 1906, W.E.B. Du Bois, and happy Black History Month. So I got to start with some Black history, right? In 1906, the national Black leader, W.E.B. Du Bois, challenged the bleak forecast and countered arguments of inherent Black inferiority in a written monograph called The Health Physique of the Negro American. And these were proceedings that were drawn from an Atlanta conference on Black health. In the conference findings, they pointed out to the impact of environmental and social conditions on Black maternal morbidity and mortality. And in commenting on the higher Black rates, Du Bois noted that, quote, the present differences in mortality seem to be sufficiently explained by the conditions of life. And for me, this has always sort of been a North Star around the social determinants of health and really thinking about how we talk about these things. I also will tell you a second story, which is personal. In 1969, I was born a preemie. My birthday is 12/31/69, so I spent like 4 hours in the 60s, which makes me super cool. When my birthday really should have been on Valentine's Day of 1970. And if I go back to vital statistics and records, in 1969, the Centers for Disease Control, and more specifically, the United States Department of Health, Education, and Welfare, which it was then called, which was the Public Health's National Center for Health Statistics. In the state of New Jersey, where I was born, the total infant mortality rate at that time was 20 infants per 1,000 live births. That's 20 per 1,000. And it was 16 per 1,000 for white people. But since race wasn't classified for others, the other category, which lumped everybody else in, was at 35.3 per 1,000. That's double the rate for all races, all other races and ethnicities. So in 1969, when prematurity was the leading indicator for infant death in the first year of life, I'm both lucky and grateful to be alive. And then the third story I want to tell you is in 1994, Black women coined the term reproductive justice in Chicago after the International Conference on Population and Development in Cairo, Egypt. And reproductive justice provided a political home for a set of ideas, aspirations, and visions in language that encompassed all of the social justice and human rights issues. So, part of the reason, why do I share these stories and what is reproductive justice and why does it matter? Well, I'm going to read the definition that we expanded upon in a piece that we did in the Harvard Law and Policy Review in 2020, where 30 Black, brown women and non-binary scholars came together and clinicians. We decided to expand the existing human rights principles that were put forward by those visionary Black women in 1994. Simply put, we said that every person has a human right to decide if and when and how to become pregnant, make family and kin, and to determine the conditions under which those things would happen. Second, every person has a human right to decide that they will not become pregnant or make family or kin or have a baby or do any of those other things, and that they would have all options to prevent and or end pregnancies that were accessible and available. Third, that individuals have the human right to parent the children they already have with dignity and the necessary social supports to be in safe and healthy environments and communities without fear of violence from any individual or any government or state. And finally, that individuals have the human right to disassociate sex from reproduction, and that healthy sexuality and pleasure are essential components to a whole human life that allows us to also have different conversations about consent. These are very different approaches when we think about health services provision or when we think about the fight for reproductive rights. So quickly, I'm going to give you 3 definitions from Merriam-Webster Dictionary, because if you think about it, retrofitting something means that you are going to adapt it to a new purpose or a new need. You're going to modify it. And if you think about it, reproductive health, the reproductive health services provision is a retrofit. Right? It is a past behavior that we think is really important that allows for people to optimize their reproductive lives. Reformation or reform is to amend or improve by change of form or remove faults or abuses. Well, one could think about the retrofit as reproductive rights. These are legal protections that allow citizens to operationalize their reproductive trajectory. Reimagine is defined as to imagine again or anew, or especially to form a new conception of or to recreate. And this is where I think reproductive justice sits, right? So I really think we're at a pivotal moment where everything we've ever valued in the health professions, in social science, in public health, in policy, and demography is all up in the air and able to be retrofitted, reformed, and reimagined. Many of the proxies that we currently use in maternal child health have been rendered almost meaningless, and I would argue they have always been meaningless by the Dobbs decision. So for example, as my good friend Dr. Joy Perry has always pointed out, marital status as a variable is a useless proxy, because when 2 poor people decide to get together, fall in love, marry, or do whatever it is that they do in terms of their legal relationship, and they decide to parent, you now have 3 people attempting to live on the wages of 2 poor people. Similarly, early entry to prenatal care will need to be reimagined in the context of our current situation, because it's not precise enough to capture that people may have spent a month or longer traveling around across state lines to receive the wanted abortion that they were unable to obtain. And so the fact that you may have had an ultrasound or seen a provider or talked to a counselor, like it's weird that that somehow would not count. But our systems don't capture this. This is one of the reasons why we need to operationalize reproductive justice alongside with reproductive health and reproductive rights. So I'm going to make 3 quick points. I'm going to pass it to Dr. Egan-Torgo. First, I want to really summarize this notion of where we're currently at. It is a grieving process for the loss of Roe. It's the first time ever that the Constitution was used to take rights away from our citizens. And, but we also have to think about what opportunities does this present to us, particularly in the context of when we've had several wins, whether we think about the laws being overturned in Georgia, in Kansas, in Minnesota, and in South Carolina. I mean, in fact, we know that reproductive justice organizations are leading the case where the 6-week ban in Georgia, oral arguments have been set for that on March 15th of this calendar year. That we have reproductive justice organizations leading the charge, making human rights arguments within our courts of law is really important. Second, we have an opportunity to really activate people around supporting reproductive health rights and justice, and to do so out of a frame of human rights, bodily autonomy, and love, right? We can really talk about everyone loves someone who has had an abortion and not have to buy into the lies and the past legal rhetoric that has been sold to us that this is a polarized issue. It's actually a very messy issue. And if we keep it about the people that we serve and not the procedures or the outcomes of pregnancy, we might be able to have some very important discussion. And then finally, when we think about access to services and we think about where we're at in terms of gender affirming care and where we're at in terms of banning books in schools and all of these other pieces, there are actions that we can do to reduce harm and to build necessary supports to get pregnant capable people and the constellation of folks around them the care that they deserve and that they seek. So I look very much forward to using reproductive justice to change the parameters of the discussions that we've historically been having, to also reject the false binary that there are sides in this. There are multiple sides in this. And the one that, in my opinion, is most important is standing on the side of the people that we serve. So with that, I'm going to pass it to Dr. Egan-Torco.
Thank you, Dr. McLemore. You are, as always, a hard act to follow, so I will try my best. One of the things that I wanted to do as not a public health person, but as a public health clinician, is to bring in a piece of what this looks like for clinicians and for the people that we care for. One of the things that I was thinking of as Dr. McLemore was finishing up her talk is a comment that a colleague of mine said to me in 1997 when I was first working in abortion care. There aren't women who have abortions and women who have babies, there are just women. And while now I would frame that differently, and I would say pregnancy capable people, it remains true. And the same people that I see who are seeking an abortion are the same people who potentially I saw 2 years ago who were having a desired pregnancy. So I wanted to look at what some of the challenges are that Dobbs is bringing for our colleagues clinically, and where some of the opportunities are for us to push back on that. And I do have slides because, that's just who I am. I'm a slide person. All right. So the first point that I want to make sure that we cover is that Roe was not our goal. I am not interested in recreating Roe. It was a floor for access to abortion care. It is not our ceiling, and it should not be the ultimate goal of our work. And part of the reason for that is that there were a lot of things that were left out of Roe. There were a lot of discussions about bodily autonomy that were not included in Roe. There are a lot of people who were left out of Roe, and specifically who were excluded after the Hyde Amendment was first passed in 1976, which was the year I was born. So I literally spent my entire life in a country where there was one access to abortion for people with money and one access to abortion for people who didn't have money. So the immediate impacts of Dobbs are the ones that we're really feeling right now. And they're the ones that are oftentimes in the media and where people are concerned about, what does this mean for me as a provider? So very briefly, there is a review of what the Dobbs decision was here. But to me, the key important piece here is that as of this writing, as of me putting the slide together, abortion is illegal in states where about a third of all pregnancy capable people in the United States live. So that is over 20 million people. What that means is that they do not have access to care that is safe and accepted by their state. That doesn't mean that they can't access abortion, because we have always had abortions. We will always have abortions. That is not going to change. But it does mean that they are potentially put in a situation where they are criminalized by where they live and the care that they're seeking. And as a clinician, I do not find that to be an ethically acceptable situation. The other piece that we need to look at in terms of immediate effects of Dobbs is that our pregnancy-related morbidity and mortality in the United States is not only catastrophically bad, it is, as Dr. McLemore noted, significantly different for Black and Indigenous pregnancy-capable people compared to other groups of people. One thing that often gets lost in the discussion about abortion care is that there are zero circumstances in which carrying a pregnancy to term is safer than having an abortion. So essentially, by banning abortion, these states have also obligated pregnancy-capable people to accept an increased risk of death and disability on the basis of their pregnancy. This is going to have some profound effects not only for the individuals themselves, because what does it mean to be told that your state thinks that your fetus is more important than your life? But also, what does that mean for the providers who are caring for people during pregnancy? I'm a midwife. What I do is I care for pregnant people and pregnant and pregnancy capable people almost exclusively. And the astonishing thing to me is always not that there are complications in pregnancy, but how many pregnancies are successfully continued to term. There are so many ways in which this can go wrong. So post-Dobbs, the bans are really concentrated in states that already had high pregnancy-related morbidity and mortality and high rates of neonatal and infant morbidity and mortality and fewer resources for the people in those states. That is going to exacerbate the situation that already existed. And so just as COVID sort of put all of the flaws of our healthcare system under a spotlight, so is Dobbs. It didn't create these problems, but it's amplifying them. And specifically, pregnancy-related morbidity and mortality and neonatal and infant mortality disproportionately affect Black and Indigenous people. This is not an accident. This is how the systems are built. And we cannot address the issue of neonatal morbidity and mortality, the issue of pregnancy-related morbidity and mortality without acknowledging that. And that is also part of how Dobbs is disproportionately impacting people of color. Both of these are going to increase post-Dobbs. There's not a lot of things that I can say will absolutely happen, but I can absolutely say with confidence that this will happen. The secondary implications are for workforce. So this is not new. Denial and delay of care in Catholic healthcare facilities has been documented for decades. Essentially, what Dobbs did was it took the denial and delay of care that was already happening in Catholic healthcare facilities, and in the states where abortion was banned, it extended them to secular hospitals. That is all it did. This already existed. This is well documented. So we know that this is going to continue to happen in states, including Washington, with Catholic healthcare systems. We have one of the highest proportions of hospital beds in Catholic healthcare systems in the country, which is interesting because we're also one of the least churched states in the country. Sort of doesn't really fit there. And for example, in Seattle, if you are seeking secular healthcare, you have one option. You have the University of Washington healthcare system, and that is it. All of the other healthcare systems within the Seattle city limits are Catholic Church affiliated. This has implications not only for people seeking abortion care, certainly. It's mismanagement of incomplete miscarriages. It's denial of contraception. It's denial of emergency contraception after sexual assault. Although that's not supposed to be allowed in Washington state, it absolutely happens. Limited options for care of non-viable pregnancies, gender-affirming health care, end-of-life care. This has implications, and what Dobbs has done is it has solidified the idea that these norms are acceptable, that it's okay to have substandard health care because you're meeting a political need. The other systems concerns that I have post-Dobbs relate to how healthcare providers intersect with the patients that we serve. Essentially, healthcare providers are being asked to become law enforcement officers. We're being asked to become part of the carceral state. Because if you believe someone has had an illegal abortion, that is a reportable offense in many states. And although the people who sought abortion are not supposed to be prosecuted in those states, that does not mean that that's necessarily going to happen. There are a number of fetal endangerment laws, for example, that a colleague of mine at San Jose State University, Grace Howard, has been documenting for years, in which fetal protection laws were used to prosecute largely Black and Indigenous people who were pregnant and generally also had substance use disorders. There was a fetal personhood case that was up to be considered by SCOTUS this term. This also presents a really large conflict between our legal and ethical obligations. Do we have a greater obligation as providers to the state, or do we have a greater obligation to our patients as providers? Why are we being required to make this choice? And it really potentially creates problems for decision-making as a provider. How do we make decisions for a patient and know that we are making those decisions for the patient and not because we fear impact from the decision that we've made? One really good example is mismanagement of incomplete abortion. So with a miscarriage, if someone is having a post-miscarriage hemorrhage, the way you treat it is you empty their uterus. When that is delayed in Catholic hospitals, it's often delayed because providers fear losing their privileges or they fear losing their employment, not because they don't know what the right thing is to do. So we're putting people in an absolutely impossible position in which they're being required to choose potentially between a profession that they love and a job that they need to support their families, and at the same time, their obligation to their patients. This represents a loss of human right to bodily autonomy. And abortion providers have been for a very long time the canary in the coal mine. No one has listened to providers. And of all the providers that I know, I can't name a single one who was surprised by the Dobbs decision, although there's a lot of people out there who seem to believe it came out of nowhere. This has been coming for a long time. And what Dobbs represents is pregnancy being enforced as misogynist violence. It does not represent a political decision. It does not represent a medical decision. What Dobbs is doing is it's creating a situation in which the condition of being pregnant allows someone to override bodily autonomy in a way that is utterly unacceptable under any other circumstances. I can't be required to donate blood to my child, but I can be required to continue a pregnancy that could potentially endanger my life. So there is a mismatch here between our ethical obligations as healthcare providers and what we are now asking of our patients. There is a real risk of moral distress and injury for providers, which can amplify the already corrosive effects of the pandemic on the workforce. The healthcare workforce, as you know, is struggling, that's a nice way to put it, under the weight of the last 3 years. What Dobbs has done is it's created another opportunity for profound moral injury and no way to recover. So what is that going to mean for staffing for labor and delivery? What's that going to mean for people willing to become primary care providers or to work in ERs? We need to think about what are the downstream effects of this on the entire healthcare system, not just on reproductive health. There are a lot of things that are coming up post-Dobbs, potentially loss of rights for LGBTQI plus people, criminalization of non-procreative sex. That is straight out of Justice Thomas's concurring opinion. Contraception. If we're defining personhood at fertilization, then every method of contraception other than barrier methods is no longer going to be acceptable. And there are a number of other possible equally depressing options on the horizon. These aren't easy times. And I put in the little chicken because it's very hopeful, right? You got a little chicken. Chickens are happy. They're powerful times. When things are disrupted, there is an option to build something better and to build something new. And that is what we have the potential to do now. So I'm going to end there and turn it over to Taylor, who's going to talk about some of the things that are being done.
Awesome. Thanks so much, Dr. Egan-Torco and Dr. McLemore. Both very hard acts to follow. Thank you so much for sharing your expertise and knowledge with us today about reproductive justice, about the post-Dobbs landscape. And yeah, I'm looking forward to our discussion. So since Dr. Judd was unable to join us today, I'm just going to talk a little bit about the current policy efforts for protecting abortion rights happening here in the Washington State legislative session that's happening right now, before we go into the Q&A portion of the panel. And so I'll give a broad overview of this legislation since I'm not a policy expert on these, but we really thought it would be useful so folks on this call know today what's going on locally related to these discussions we're having today. And I'll go over 5 primary bills that have been introduced in the Washington legislative session this month. And I want to be explicit that these are legislative efforts related to abortion and reproductive rights, but not reproductive justice as a whole, which Dr. McLemore spoke about, and goes beyond abortion to encompass the right to have children and raise them in safe and healthy communities. And so there's a lot more that we can be doing, but these are just abortion related that I'll go over right now. So the first is the Keep Our Care Act. This act ensures that mergers and acquisitions of healthcare systems, such as hospitals, improve rather than harm access to affordable quality care. And this speaks exactly to what Dr. Egan Torko was speaking about with the Catholic hospital expansion happening in Washington state. So these large corporate health systems have been taking over smaller community-based healthcare, and these unchecked mergers can drive up prices and restrict access to critical healthcare services, including and primarily abortion. So after decades of this occurring, like Dr. Egan Dorgo talked about, 50% of hospital beds in the state are controlled by healthcare systems that have policies to deny patients abortion, gender affirming, and end of life care. And these mergers and acquisitions can exacerbate systemic inequities and can result in further delays in abortion care, which increases patients' physical, mental, and financial risks. So the aim of the Keep Our Care Act is to protect access to quality, affordable health care. The second law is called the SHIELD Law, and this bill will strengthen legal protections for abortion providers, patients, and helpers in Washington state by preventing local entities from cooperating with out-of-state investigations. And this bill is intended to shield patients and providers from being criminalized for providing or accessing abortion or gender-affirming care in Washington state. And as our panelists sort of previously discussed, there's an influx of out-of-state patients in Washington state post-Dobbs. And right now, there's a lot of uncertainty for providers and patients who face uncertainty about whether they could be criminalized for seeking or providing legal abortion care in Washington. So the goal of the SHIELD law is to have Washington provide refuge to patients and protect the healthcare workers who provide these vital services, like our two panelists. The next bill I'll talk about is the My Health, My Data Act. So this act will protect people's personal health information by preventing it from being shared without their consent, including with law enforcement in states that criminalize abortion and gender affirming care, or with fake clinics known as crisis pregnancy centers. So for folks who don't know, crisis pregnancy centers, which abbreviated to CPCs, they are anti-abortion organizations that divert people from receiving abortion care by using coercive tactics and medical disinformation. So in Washington state, CPCs outnumber abortion providing facilities 2-to-1, and they position themselves strategically to target low income, young, and marginalized communities. So under the current law that we have now, Washingtonians' health data is left vulnerable to be used by advertisers or shared with anti-abortion groups. Some examples include period tracking apps that can sell sensitive information about a person's late period or miscarriage to data brokers, which can then be sold. Pregnant individuals who sometimes contact or visit CPCs, these crisis pregnancy centers, looking for reproductive health care services, only to find they can't receive an abortion at that facility. But while they are there, that CPC can collect and share the individual's sensitive data with anti-abortion groups who can target them with anti-abortion messaging and ads. So this new legislation, this My Health, My Data Act, prohibits organizations from selling Washingtonians' health data and block apps and websites from collecting and sharing health data without consent. It also prohibits geofences from being used at reproductive and gender-affirming healthcare facilities. So geofences are a virtual perimeter around a physical location that can be used to send messages to a person who enters a specific location. So the fourth bill I'll talk about today, there's obviously a lot on this legislative agenda, is the ending cost sharing for abortion care. So this bill would require insurance companies to cover 100% of the costs for abortion care procedures and services. Currently, when patients receive care covered by their insurance plan, they share the costs in the form of copays, deductible, or coinsurance. And ending this cost sharing would make abortion care more accessible by ensuring that patients can access care without cost to themselves. And just to note, this only expands abortion access or supports abortion access for folks who are insured. The fifth bill I want to talk about is the Protecting Provider Licensing and Malpractice Insurance. And this law would ensure that care providers can continue providing abortion care in Washington, regardless of the actions taken in states with abortion bans. And I'll add one final mention. There was a Senate joint resolution to amend the Constitution to the Washington State Constitution to address reproductive freedom. Constitutional amendments require a 2/3 supermajority vote in both chambers. And right now, folks are saying they don't have these numbers yet in this session, but it's still early-ish in the session, so we will see. So I did want to speak a little bit about so that's sort of Washington State, where a lot of us live and vote and are to know what sort of our representatives are doing. Also wanted to speak a little bit about in Seattle, where many of us also live, and City Council passed legislation protecting abortion access after the overturn of Roe this last summer. So some examples include prohibiting false and misleading advertising by crisis pregnancy centers. Similar efforts have been done previously by the King County Board of Health, which passed an ordinance in 2017 that CPCs must present a disclaimer that they're not a medical facility, though many of these CPCs have found a way around this regulation by hiring staff who hold some type of healthcare provider certification or accreditation. The City Council also allocated $250,000 of city funds to expand abortion access via the Northwest Abortion Access Fund, which is our local abortion fund. And they established Seattle as a sanctuary city for those seeking abortion care and adds people seeking abortion as a protected class to ensure their civil rights protections. So while these are all important steps to bolster and expand access, abortion access in Washington, there are still existing structural barriers to care across the state, particularly for marginalized and minoritized, low income, and rural communities. And like our panelists have said, these have been long-standing inequities far before Dobbs. These inequities have been here in access to care, and these structural barriers are still here. So I think there's an idea that Washington has we're fine post-Dobbs, but as our panelists have brought up, there's a lot of access issues for many in the state. And before we go to the Q&A, I do want to chat briefly. I know we have lots of students on the call about a UW student-led policy effort for medication abortion at public university student health centers. So a student-led grassroots group proposed a draft legislation similar to what the states of California and Massachusetts have already done, and New York is currently pursuing, for requiring public universities to provide medication abortion for their students at their student health centers. So this was based on a study we did estimating demand for medication abortion among public university students and the geographic, travel, cost, and logistical barriers that students face when seeking care across Washington state. So there's been some interest from representatives and centers in this. It's unlikely to advance in this session, but we'll keep building coalition with campuses across the state for the next year and continue advocating for this at our individual campus, like at Hall Health here at UW Seattle. So if there's students on the call that are interested, please reach out and join us. I think we'll transition now to questions. So folks, panel, audience members, please add your questions to the chat. And I've seen some things coming up in the chat.
Yeah, what we're maybe sorry, Taylor, encourage folks to put things in Q&A.
Sorry,
yes. I've been sharing Dr. McLemore's comments to everybody, and it's hard for us as panelists to put anything in the Q&A. So, but thank you for those. I was wondering, I did capture 2 of the bills. I was going to put them in the chat, but I didn't get all of them. So if you could give me the bill numbers, I'll send chat messages to everybody on the legislation that you mentioned.
Sure thing. Yeah, I can send that.
I have 5241. I have a link to that, and I have a link to 1155, House Bill 1155, but I didn't catch all the two others that you mentioned.
Great, I'll add those. And Dr. McLemore, do you, sitting on the Washington People's Privacy Team, do you want to add any more information about that My Data, My Privacy Act?
I do want people to pay attention. I actually want to connect the dots for the participants because I know that there's more people on Zoom and than are in the room. And so I want people to understand that the privacy implications that are part of, My Body, My Data, it isn't just specific to abortion care, right? I mean, I think Dr. Egan-Torko said this really, really well. Like, abortion repro has always been the canary in the coal mine. And so when we start to think about, other data privacy issues around not just apps either, right? I mean, even we know people have been mining EHR, electronic health records, for data for years. And so there needs to be more supports for privacy and how those data are used. And this bill sort of reconciles a lot of the loopholes that are I think, created or exploited by, de-anonymized patient data versus what you have access to versus what can be sold, right? So there's all these different sort of layers to it. So the My Data, My Privacy, it's actually a little bit more comprehensive than just thinking about abortion specific. Like, that was the thing that allowed us to really push it forward, because I mean, what's the most private decision that you can make? Right? I mean, but it also has other implications for the rest of healthcare. And I think that's the point we're trying to get at here, is that reproductive justice isn't just about the propagation of the human species. It's also about this broader, like the reproduction of ideas, the reproduction of opportunities. Like, it's a broader thing. And so we want people to understand and finally connect the dots around, and to Dr. Egan-Torko's point around religiously affiliated healthcare. This came up in the PEB meeting yesterday. So full disclosure, I was appointed by Governor Inslee last year to take on the huge shoes of Yvonne Tate. And if you didn't know her, she's a big time civil rights lawyer, incredible woman who spent a lot of time on the Public Employee Benefits Board, making sure that there was parity, and particular sex and gender parity on the board, to be able to make sure the benefits that people had access to, both as current beneficiaries as well as retirees, would really be reflective of protection of rights. So yesterday we had a lot of conversation about fertility benefits. We had a lot of conversations about protecting gender affirming care. We had a lot of conversation about abortion because, a lot of the people who are covered by the Public Employee Benefits Plan are worried about loss of those services, given how many religiously affiliated institutions that are providing care, outside of Kaiser Permanente and UW in the state of Washington.
Thanks so much, Dr. McLemore, for that background and more context to that. That's really useful to know about. Again, attendees, please add questions to the Q&A function. But I actually want to go off one aspect you were talking about, Dr. McLemore, about the broader principles of reproductive justice that you've opened with. And this week, we've seen yet another state-sanctioned murder of a Black man by police. Tyree Nichols was killed after a traffic stop in Memphis, Tennessee. And Dr. McLemore, can you speak to how police violence is a reproductive justice issue and how these are all connected?
Yeah, absolutely. I mean, we held space for students, faculty, and staff on Wednesday to the Center for Anti-Racism. And actually, we're going to be changing our name, which I'm super excited about. We're going to be called CARE in Nursing. And where CARE is an acronym that stands for Center for Anti-Racism and Equity in Nursing. But police violence and voting rights and all of these are all reproductive justice issues, because when you think about the role of the federal government in terms of, protection of rights of citizen, we allocate our resources supposedly in what we call a social safety net. Right. And we think that there are certain supports that citizens should have. And some people conceptualize this as safety and they operationalize it as police. not really understanding that there is a disproportional, murder of unarmed Black citizens. And quite frankly, gun violence is also a reproductive justice issue, because when you think about it, the number one reason for maternal morbidity and mortality is homicide, right? If you take out any physiological issues of the pregnant capable person, homicide is 3 or 4 times more likely to cause the death of a pregnant person. We've seen that in Dr. Maeve Wallace's work at Tulane University. So when we think through police violence as a reproductive justice issue, number one, it's not a health and safe community. Number two, in the same way that we saw with George Floyd, we saw Tyree Nichols calling out for his mother, right, as he was being beaten. When we think about the fact that when a community loses a person to unarmed state-sanctioned violence, that we've lost a family unit member, and therefore that has intergenerational impacts. He is a father, right? So this idea of when we can't separate out the healthy, safe environment piece, and this is where I get very frustrated with anti-abortion people, because they want to say that the womb is the most dangerous place for an African-American child. They'll put that on billboards in Times Square. But the truth of the matter is the most dangerous place for a child or a Black adult is actually being policed in their own community. So this false equivalence around safety and this false equivalence around what is reproductive justice, well, justice means that you actually have the opportunity to grow old. You actually have the opportunity to thrive in the community in which you live, that we will put the supports that are necessary in place for you to be able to, expand your education opportunities, to be able to, build a life for yourself. And right now, our gun laws don't allow for that to happen. And our over policing of Black and brown neighborhoods also does not allow for that to be a real thing. And we have an opportunity now to really ask people and press them to put their money where their mouth is. The other thing we could talk about that hasn't also been talked about that I think is a huge deal is the momnibus, right? The set of bills to really improve maternal morbidity and mortality, to really think about. We don't even have paid family leave, right? So you got people talking about all these different factors as if they're not interrelated, and they are. And that the more we can get people to, this is why, so going back to the 1,000 things I have to say about demography, because that discipline is really grounded in a eugenicist notion, right? This idea that we're going to do population counts for the determination of allocation of resources, right, is very strange to me, because I'm a student of public health and Dr. Kamara Jones, who says we should distribute our resources based on need, right? So I think that there's room for a whole lot of different discussions, and reproductive justice opens us up to have the language to be able to do that.
Oh, thank you so much, Dr. McLemore. I hope y'all are taking notes. I really appreciate that interconnection of how all of these are interconnected in reproductive justice as this framework to do that. Jessica, I believe you have a chat or a question in person, if we want to shift to that.
Yeah, it's actually from me, and I can't put anything in the chat. But it's sort of adjacent when we think about reproductive justice and everything that it encompasses beyond abortion, and returning to this idea of privacy around our health data. I'm wondering if anyone on the panel can talk a little bit about children who can become pregnant and how they are dealt with in a post-Roe world. The rights of children to have privacy from their parents when it comes to medical data. And also, I think the biggest sort of anti-abortion talking point around adoption and where that plays in rights to reproductive justice, particularly in light of challenges against ICWA, and how adoption has often been part of settler colonialism and genocide as well.
Yeah, that was a lot. So I think I'm going to start backwards, and then I'm going to pass it over to Dr. Torko, because I want to take on this adoption piece, and I want to take it on because one of the premier researchers who who does science specific to adoption is Dr. Gretchen Sisson. She's a sociologist at UCSF and a colleague of mine at AMSR. And, you know, she's been trying to really push reproductive justice people to do more, you know, on adoption. And my whole thing is adoption is it's actually not an abortion decision. That's not where the dichotomy sits. It's actually a parenting decision. And so, and given the disparities in child welfare, and Dorothy Roberts has outlined this beautifully in terms of child protective services involvement and all of that, there's a whole lot of healing and repair that has to occur before we can have a conversation about, you know, adoption being an alternative to abortion, when it really actually is conceptualized, at least in Black communities, as an alternative to parenting. But when you layer on top of the child protective services piece and involving child welfare and removing children from homes and all of that, like that whole situation is, I think, juxtaposed around the involuntary removal of Native and Indigenous children from their homes, right? Where you've got a state deciding that children can be removed, but then that has to be forced on to people so that they can maintain their own bodily autonomy. Like that whole argument is very strange to me. And so I get very frustrated when people talk about that. The other thing I'll say about the privacy piece, and this is really important around children and youth and all of these other pieces, right? Young people, well, this whole age thing is fascinating, but young people actually are emancipated minors in the context of pregnancy. Right. So they are able to make their own decisions around their own bodies and in consultation with their clinical team. Right. But as we saw in many of the sad and tragic cases around the country, the Ohio one in particular, where we had a 10-year-old person. Right. Because we talk about the outcomes of pregnancy as if they're equitable. Right. When we know that carrying pregnancy to term is 14 times more dangerous than actually having an abortion at any trimester. Right. Or at any time point. And so people have been conditioned by lies to think that pregnancy is in and of itself without risk, when that's not true, right? And at the young end of the spectrum and at the old end of the spectrum is where we see danger in pregnancy manifest the most, right? So when you look at the Black women are 3 to 4 times more likely to die in childbirth and pregnancy-related complications from the Centers for Disease Control and Prevention statistics, that's people on the very young end of things and people on the very old end of things. And so to tell a young person that they do not have capacity for bodily autonomy, but then to also tell them that they have to take on risk that is above and beyond, right? I think that we as a society really need to wrestle with, like, who are the true arbiters of decision-making around what risks someone should or should not have to take on in their lives, knowing that there is nothing in life that is not without risk. Anyway, I'm going to pass it to Dr. Egan-Torko for her thought.
So I'm the survivor of 3 high-risk pregnancies that became very close to killing me. And I'm also the parent of 2 teenagers. I think that we can't separate out how we treat minors in pregnancy from the idea that is deeply rooted in capitalism, where we think of children as the property of their parents. And that is a larger issue that we need to sort out as a culture and as a healthcare system. And we need to be able to identify the ways in which we can support teens and emerging adults as they become ready to make their own decisions, which in Washington state is pretty much once you've passed puberty, you get to make your own decisions about your reproduction. It is not the case in other states. But this is really tied up in the idea that we have ownership of our children, and we don't. So rather than thinking of this only in the context of how do we get young people access to abortion, we need to have a larger conversation about how do we recognize the autonomy and the rights of people that exist before they pass this magical age of 18. Because I'm here to tell you that my kids were not any better at doing things the day after they turned 18 compared to the day before. It is a process for all of us. So how do we keep this from being an arbitrary point in which we get to make decisions for another person that are going to affect their whole lives and that are going to affect potentially whether they continue to have a life?
Thank you both. So we've got another question in the chat. Besides the student-led access to medication abortion movement, how else can attendees get involved in policy actions to expand access? I know there's a Huskies Day next week if folks are interested in that, but I want to leave it for Dr. McLemore and Egan Torco to respond to that.
Well, I mean, there are several national advocacy organizations that are available for people who are currently enrolled in school, regardless of what level of education you're at. So there's Med Students for Choice, there's Nursing Students for Choice, there's actual organizations that are trying to come up with collective strategies in each of the states, really trying to provide clinician training, to provide advocacy support, media training, logging into different kinds of programming. And then right after the Dobbs decision, my good friend Liz Winstead, who runs the Abortion Access Front, which used to be called the Lady Parts Justice League, they did a whole activist training that I thought was really, really helpful. And then the National Network of Abortion Funds, they're always looking for volunteers and practical support to be able to show that love for people who are having abortions, to provide rides and other kinds of means to give support to people who are having abortions. And it's not just abortions, it's also miscarriages and other kinds of pregnancy outcomes, right? They're even starting to help patients who are going through infertility treatment. So I think that we could reimagine that mutual aid, that social support. That's where I think the greatest need is right now. Dr. Egan Torco, you have other thoughts or suggestions?
Really just that we are all embedded in communities and in systems and in organizations. And oftentimes what it takes is drawing that connection between something that doesn't seem to be related to reproductive health or reproductive justice and the other issues that are going on. So if you're a healthcare provider or a healthcare professional, being active in your professional organization matters. It matters if you talk to your elected representatives. It matters if you have conversations with each other. One of the things that has always been striking for me is how many of my patients say, I don't know anybody who's had an abortion. And I'm like, yeah, you do. You just don't know that you know. And so even telling our stories and telling them to each other and not stigmatizing abortion the way that we do can be really powerful in terms of opening up the ability to have that conversation with policymakers.
Catherine is available to ask her question. Catherine, you can unmute yourself.
Yeah, thanks so much. I really appreciate it. Thanks so much for hosting this panel. I typed my question in the chat, but I'm joining you all from over to the east in Idaho, where we have multiple abortion ban triggers that have passed. And I've been struggling to understand what new obligations that providers have, obligations and restrictions that providers have around their knowledge of patients' abortion-related behaviors and practices, and thinking through, like, are there types of information I should not be sharing with my provider given the new obligations that these laws may place on them?
I can guarantee you that your providers are struggling with exactly that same question.
Yeah.
It's very unclear at this point. One question that we as providers are asking ourselves is, should we be doing pregnancy testing without having specifically informed consent about that pregnancy testing? So the bottom line is, unfortunately, we don't know. What you share with your provider is supposed to be private. It is supposed to be protected. That is literally how I do my job.
Yeah.
But as of right now, we don't know what that's going to look like in Idaho.
Yeah. Yeah. Thank you.
I thought I would just quickly, before Dr. McLemore leaves, I don't know why I'm having trouble, to say quickly that I think we have a chat here around data and the construction of data, the social political processes of the construction of data, and want to say that there are a lot of us who are very concerned and want to work on and think through how do we not only acknowledge the demography, the bad, ugly history of eugenics and how demography is rooted in that history, but how do we overcome it? And would love to continue that conversation. We've had in our training program, students throughout ask questions. Both our demography and society class starts in the eugenics movement. It starts with talking about what that implication is. And that thread gets carried through in questioning which categories we compare, why we compare particular categories of people, what are the implications of those comparisons, what were the reverberations of those comparisons in terms of creating persistent inequality and injustices. And so if anybody's interested in continuing those conversations in a more systematic way, I know we have students who care about those questions and we have faculty who care about those questions, and we would be happy to support a community of conversations, especially around that intersection of the construction of data, the use of data, statistics in perpetuating inequality, and hopefully figuring out a new way in which we can use that to our advantage. As W.B. Du Bois suggested, we have to be visible, and we have to figure out how to make ourselves visible in a constructive, change-making way.
Right. Well, we're definitely over time. I want to say a very big thank you to our panelists. This was a great discussion. Clearly, we could have gone on for another hour. So thank you all for joining us, and hopefully we can have another sort of a secondary panel sort of a follow-up to this at some point in the near future.
Thank you. Thank you so much. Thank you, Anjum. Thank you, Taylor. Thank you, Dr. Egan, Dr. Claremont.